So we are live now on YouTube, sir.
I think you can start PTS.
Yes, sir. Yes, sir.
Yes, you can also start for the recording.
Yeah, once I think Singaravadivelu sir starts, then I'll start the recording.
Okay.
Oh yeah.
PTS சார் நீங்க ஸ்டார்ட் பண்ணிடுங்க சார், வெயிட் பண்றேன்.
Sir, start பண்ணுங்க சார்.
இல்ல சார், நீங்க இன்ட்ரோ듀ce பண்ணிடுங்க சார் நம்ம மாடரேட்டரை.
Okay.
Yes sir.
So on behalf of Tamil Nadu Orthopedic Association, I welcome you all to the TNOA PG teaching program's fourth program. The topic is clinical examination of elbow. So moderator is Professor Dr A Sureshkumar. He is one of the coordinator of this program. He is a professor of orthopedics from Tirunelveli Medical College, Tirunelveli. So speaker for this day is Professor Dr V Singaravadivelu. He is a professor of orthopedics from Institute of Orthopedics and Traumatology, Madras Medical College, Chennai. So over to Dr. A Sureshkumar, the moderator.
Thank you, sir. Thank you, PT Saran, sir. Good evening, everybody. So today we are going to start the fourth program of TNOA PG teaching program. I am very proud and pleasant to introduce my teacher, Professor Singaravadivelu, for this session of elbow examination. Our professor, our faculty today is a professor of orthopedics in the Institute of Orthopedics in Chennai, Rajiv Gandhi Government Hospital, Madras Medical College. Even if not the first year postgraduate, the second year postgraduate, or the final year postgraduates are maybe knowing his name. He's been quite flashed across in many of arthroplasty CMEs, webinars, etc. He's been popular in the revision scenarios of arthroplasty. I have personally seen many of arthroplasty sessions by him. Is one of the pioneer in taking forward the Stopas approach. In fact, we are impressed by the way in which he was doing Stopas approach, and we started doing Stopas approach in some of the cases in the pelviacetabular trauma. Plus, he is also an important person in the handling pelviacetabular trauma. He happened to be a chairman of the AO trauma symposium once, and if you recently aware, you probably might have, some of you might have seen the video or the IOA teaching program, one man, one topic program. I think last month it was said. Professor was talking about the giant cell tumor. It was a totally new concept which I was stunned. The reason being that all along we are doing bone graft in many of our situations. We do bone grafting, trauma, replacement, many times we do it. The thing here is he cured the cavity, meticulously he cured the cavity. After curing the cavity, he didn't he didn't stock any bone graft there. He just leaves the cavity empty. Remember, the cavity is left empty, which is against the concept which has been practiced so far. We never leave any cavity as far as orthopedics is concerned empty. We always fill it with something. We leave the cavity empty and then put two metallic screws for support or even a fibular stud. So it is a column which has been supported. And he took example of a pelviacetabular trauma where the anterior as well as posterior columns are supported. When these columns are supported, he means to say the quadrilateral pit is filled with bone. The same concept he applies here. And I was stunned by this concept, and I really thinking about whether even in trauma conditions, bone grafting is necessary or not, or can we leave it as such? Because he says, you apply bone graft and the chances of recurrence is going to be high. You are seeing in a lot of cases, this is not a single day decision. It has been in practice, and he has observed these things in the past. So this is a stunning new concept. You probably might have impressed by this approach. So this particular the topic of the topic is, there is always a new thing in the GCT. The journey is even before I joined the post graduation in 2002. Even in those times, was meticulously collecting all those X-rays, post-operative X-rays, and collect them and store them in the digital cameras, as well as we have a department computer, we stored them. And the PG who is sitting in the review meeting used to collect the X-rays and he stores in the computer. On the duty days, he does duty on Saturdays in the week. In the evening time, we used to see or monitor whether all the PGs are doing and collecting the X-rays. So this is a very important concept. Now, doing work is one thing, documenting your work is another thing. Only document your work, only when you collect and store your information. This is being brought up to the level of publication. We Indians lack in publication because we don't document it. So this particular documentation, he gives such an importance, and he stores and collects his X-rays from the even before my postgraduate days. So I postgraduate should learn this importance of documentation. And if you really want to highlight his academic feat, I will say the PhD degree he was awarded from Dr. MGR Medical University for the topic of the role of body mass index in varus deformity of the knee. So this is a great feat which many of our faculties don't try due to some reasons, but he has achieved this amidst his busy schedule of practice. Many of his works are in the online, in the pipeline of publication and likely to be published in a matter of years. So we must learn certain things from him. The passion for orthopedics, the way he documents it, and the way he publishes and tries to publish, and way he thinks. So this hard work and all those things only postgraduates do. And his particular attention to the academic one is the one which fetched a PhD degree for him. This is the qualities which you have to infer from Dr. Singaravadivelu. So now it is over to Professor to talk with you, the postgraduates. Meanwhile, I like to also introduce my postgraduates, Dr. Azaria and Paul Ram Shankar, who will be interacting with our professor in the meanwhile. You can also post your questions in the chat box. Already there are a few questions. So at the end of the session, I will definitely answer this question to ask the questions to the professor, and he will answer. Okay, over to Professor Singaravadivelu.
Thank you, Dr. Sureshkumar, for those nice words. Really, it was very joyful to see one of my postgraduate now who is a professor and being a faculty and doing very good work. So the pride for the teacher always is seeing the postgraduate students who were his students and now doing good work and being appreciated. So I happened to listen to Sureshkumar a few times and it was really wonderful. So I was very happy and proud, Suresh. Thank you.
Thank you, sir.
So let us go to the clinical examination, the topic of the day. So at the outset, I wish to thank our respected President of the Tamil Nadu Orthopedic Association, Dr. Tirunelveli, Honorary Secretary, Dr. Saravanan, the TNOA PG teaching program, my fellow colleague, Professor Vetrivel Cherian, and the coordinators who are doing a wonderful job and taking in these difficult times, so teaching to the postgraduates when nothing is happening. So I thank our Professor Thanappan, Professor Sureshkumar, and Professor Tirunarayanan. So with those few words, let us go to the main topic of the day, the clinical examination of the elbow. So when we see the elbow joint, so next to hip, I will put it more than the hip about the elbow joint. Even the hip, we will say that it is with 4 diagnoses, whether it is synovitis, arthritis, ankylosed hip, or the unstable hip. These are the 4 broad categories, and you bring out all the relevant points, and most of the time we'll be dealing with hips, and repeatedly the examination aspect is being dealt with. I would say that it is little bit better off. This elbow joint, it has got a lot of surprises. Like in an abdomen ward for a general surgeon, it is a Pandora's box. There are a lot of surprises. Even as an examiner, we discuss and we think that the diagnosis is this, and entirely to our surprise, there may be few other things which may be seen in the X-ray. So elbow joint is one which we have to pay a lot of attention. And what as an examiner would see is, because it is most of the time it is only short cases. So the postgraduate student to examine thoroughly and elicit all the clinical signs and able to correlate everything and try to arrive at a diagnosis, leave alone the X-ray finding. Because one thing which can pull you down is getting a tip and trying to fit everything, the clinical signs, and then getting caught in the examination. So try to be very strong in the elbow examination and try to correlate everything like a mathematics, because most of the time in orthopedics, I would say that it is maths. So try to arrive the equation and then try to solve the problem and get into the diagnosis. So once you get into the diagnosis, and if you come to the X-ray, if it is entirely surprising, that's fine, because most of us as an examiner, We'll not see the X-ray first, and we'll also examine together with the candidate most of the time. And if the diagnosis is different, then it's fine. We absolutely appreciate that. So with that in mind, I'll be concentrating more on examination aspect and not on much of theory. This is not going to be a comprehensive lecture on elbow examination, everything together in this PowerPoint. And it is going to be only the relevant points, the mistakes where we made, and try to clear all those things. So with that, we have also two of the postgraduate students, the Azaria and Paul. So let us ask some questions and make it interesting. So first we see this elbow. He is a bodybuilder and this elbow looks fine. So let us ask Azaria. So can you just tell me what it is, the left elbow, because there is some problem in the left upper limb, mostly towards the elbow joint. So what do you see and what else you want? How do you want to proceed? Can you just guess? Find out if it's abnormal?
Good evening, sir. Sir, the biceps is more prominent, sir.
Okay.
It's like a Popeye sign.
Okay. So Popeye sign is what is it actually?
It is a biceps rupture, sir.
Where?
Proximal.
Proximal. So it will come distally. So this that Popeye sign is long enough biceps getting ruptured proximally, and it comes. So what would you like to see before you confirm that it is something like that? Because he's a bodybuilder, a well-built man. You can see the pectorals, deltoid, everything. He's a well-built man. So what would you like to see? So I would like to see the opposite elbow. Okay. So first, to confirm whether it is that, you have said that the biceps is prominent. Is it really prominent? You're absolutely correct that there is some problem in the biceps. So you must expose the elbow on either side adequately and appropriately, and then try to see both, find out whether there is any asymmetry, look from all sides before you go for your findings. So that is most important. Just don't go see only once and then you come to a conclusion. So I would have appreciated that. So I would like to compare it with the opposite elbow, find out whether there is anything abnormal, and then I'll try to make a diagnosis. So don't be in a hurry. So examine adequately. That's what I would say. So he is exactly right. So if you can see that this biceps bulge is little more proximal and it is more prominent in the left side when compared to the right side. So just ask him to flex it. So this obviously the basal mass is getting pulled up. So this is a distal rupture of the biceps tendon, which is taking up the biceps. So the examination, virtue of examination and comparing it with the opposite side is very, very important. So with that in mind, we'll go for the examination. So history, I'm going to be very, very brief. History is whether there is any history of trauma, I have to find out. When there is a trauma, how the patient has sustained the trauma. It is very, very difficult, like an ophthal examination, whether this power suits you, that power suits you. Very difficult when you sustain injury only when you know. So how he landed, but still you will have to find out whether he landed on the point of the elbow, or was it a fall on the outstretched hand, or was it on the sideways, was it a direct impact? So the mechanism of injury you will have to say. Then very important is that you have to elicit the history of massaging. Very important, as you all know, to find out whether there was any predisposing factor for a myositis ossificans. Then the treatment history, you have to little bit elaborate. So after massaging or without massaging and immobilization, whether any implant was applied and then removed, a KOA application and then removal, after some time when the patient comes, he might forget. So any implant going inside and coming out, it might cause, because if it is a pediatric age group, it might cause some growth disturbance, it may. So those things you have to keep in mind, the history of what is the treatment history. And the second will be, next to the trauma will be inflammatory arthritis and enthesitis. So you have to ask about a generalized, because being a short case, once the patient comes, you must quickly, as you are examining, 15 minutes is the time which will be given. So you will have to ask the relevant history. You need not say all the negative histories, but if it is a vague pain in the elbow and if you are suspecting arthritis, then you have to ask the relevant history according to that. And of course, infection, tuberculous infection anywhere. So ubiquitous, it can happen in the elbow joint also. So with that history and with we hope that everything you would have asked, we'll come to the inspection of the elbow joint. So once we come to the inspection, as I said already, it has to be adequately exposed and then start inspecting from the front, from the side, from the back, and also on the medial side. So we'll just see. So this boy is having Last time it was beautifully discussed. So you see from the side, you can see that there is some hyperextension which is happening, and the gunstock deformity which was there, which was seen. So we have to make sure, and what is the deformity. So what are the components? So you have to look from the front. You have to see the elbow crease, the carrying angle. The carrying angle, obviously, you can comment only if the patient is able to extend completely. Full extension must be there, and the forearm must be able to supinate. If it is not there, if there is a pronation deformity, is not able to supinate fully, or is not able to extend completely, you'll have to tell the examiner clearly, I am not able to comment about the carrying angle because the patient is not able to extend or keep it supination. Because if it is pronated, the carrying angle is obliterated. If there is little flexion in the elbow, then the rotation of the shoulder will affect the carrying angle. So if you internally rotate, it will look like as if it is in cubitus varus. If you externally rotate, it will look as if it is in cubitus valgus. So that point you must always remember. You can just tell, sir, he has got a flexion deformity, so I don't want to comment about the carrying angle. That is one. On the lateral side, you have to see about the anteroposterior girth, the triceps, how it is, the position of the olecranon, and the relationship to the elbow joint. And posteriorly, of course, about the triceps, the olecranon, and the three bony points, their relationship, everything. So this is about inspecting. So if you are inspecting, if there is obviously a prominent olecranon, you'll know either it can be a supracondylar fracture or it can be a posterior dislocation. So these are the intercondylar with supracondylar because he is being an adult. So most often is intercondylar with supracondylar. Isolated supracondylar can happen more often in a pediatric age group. So whether there is a heel cord sign or a tendo Achilles sign, you have to see. If there is a supracondylar fracture, most often, I mean, if it is extension type, the distal fragment extends, olecranon will be prominent, but the triceps will not be prominent here. If the triceps is prominent here, it will give an appearance as if the tendo Achilles getting inserted into the calcaneum. So this tendo Achilles sign or the heel cord sign you will have to see to find out whether it is a elbow dislocation or a supracondylar fracture extension type where the distal fragment has gone posteriorly. So this you will have to observe on the looking from the sides. Then we will come to fixed flexion deformity. So this is very, very important. How do you assess? So Paul, can you just tell me roughly how much is the fixed flexion deformity of the elbow? This lady has got, this is the maximum amount of extension. What is a rough?
Good evening.
Good evening.
Good evening, sir. For fixed flexion deformity, we cannot assess by standing. We have to ask the patient.
You're not able to hear. Paul, your voice got muted again.
Table and then with the flexion of elbow.
Your voice broke in between. So you don't want to guess it here.
Yes, sir.
Very good. So don't be in a hurry to guess about what is the amount of fixed flexion deformity for this lady, because you might tend to underestimate. So why do you want to keep that on the table? Why don't you just tell? Why you want to keep that arm on the table and then absolutely right. But why do you want to do that?
To eliminate the compensation by the shoulder.
Very good. Excellent. So how does the shoulder compensates?
By internal rotating or external rotating. Sir?
How the shoulder by internal rotation, it so you think that the shoulder is internally rotated or externally rotated? Does it affect? Because he's keeping it by the side.
Yes, sir.
There's only supination pronation, is it not?
Yes, sir.
That is not going to cause anything to the elbow flexion deformity. So it is, if you see, this is the axis of the body. So what they do is, if there is a fixed flexion deformity, they tend to hyperextend or extend the shoulder and try to mask this flexion deformity. So they try to extend this shoulder. So this we fail to identify. So we tend to normally, you will say with this, it can be probably 30 degree or 35 degree. So if you see here, this is what Paul was mentioning. So you have to keep the arm on the table and then try to extend it. So if you see that and then keep the goniometer on the axis of the arm, this is on the lateral epicondyle and this is in the axis of the forearm. So if you see that this is almost 60 degree, this definitely you won't have. So when you are in a hurry, 15 minutes is the time. These are the things which you should not overlook. So this is what we would like to see. Because this hyperextension or the extension of the shoulder tend to reduce the amount of magnitude of fixed flexion deformity here. So we tend to see here it is almost extended. So if you see this axis, it is almost like 30 degree. But if you keep the arm on the table, so always in the upper limb, when you want to discuss about the deformities, you try to keep it, stabilize it over a flat surface, and then try to see whether it is hand or whether it is elbow. You have to keep it on a flat surface and then look for the deformity. So this is the amount of deformity. Very nice. So that is about the fixed flexion deformity. And most important, which you must not forget, is 3 bony point relationship. So this 3 bony point relationship you will have to see in the palpation, as well as you have to measure and then tell what is the exact relationship. So obviously you know about the 3 bony points, the medial epicondyle, lateral epicondyle, and the olecranon. So how do you see that? So if you see that, the important things you have to keep in mind are both elbows must be in the same degree of flexion. Then only you have to see, because if the flexion is not correct, if it is more flexed or less flexed, so then the distance will alter, the angles will alter. So you have to keep both elbows. So how can you do it? So these are all things, few cases if you have presented, the examiner when he is seeing, he'll be able to pick out whether you have done all those things before and you have presented it, or if you are clumsily doing it, then they'll be able to identify that you have not done enough number of cases, enough presentations. So if you are very fluent, even there are few mistakes, definitely we tend to overlook. So this short cases are one which usually determines our result. So be careful about it. So you see that you can just ask the patient to keep the hand on the pelvis so that the flexion is same, and then try to palpate. So you keep your middle finger on the lateral epicondyle, the thumb on the medial epicondyle, and the index finger on the olecranon. So you just see. So this is one method. You just keep, and you have to see both the same time, and then this side. Okay. So this is how you have to show. So this is one. The second method is you can just extend the shoulders both and allow the hand to the forearm to hang. So by this way also, if both are in the same plane, then the flexion of the elbow will be the same. Then this way you can see the triangle. So this is very easily you can see the triangle. So this is the second way. You can just do it. Or third is you can just ask them to keep it over the head. So this way also you can just see the 3 bony point with the same degree of flexion. So these are the 3 ways in which you can see the 3 bony point relationship. So both have to be seen simultaneously, and you have to show it to the examiner that this is the way I have seen. I think it is clear for you. So these are the 3 methods. So 3 bony point relation, 3 finger test. So you can just keep the thumb, index, and the middle finger to find out the relationship. So we'll come to individual cases. So what are the few cases? Last time supracondylar you cannot discuss more. Probably I can show some videos, but it was wonderfully discussed by Suresh Babu and the entire team, Samuel and all the people who contributed. So the 3 components, you know, hyperextension, internal rotation, and the medial impaction. So that I'm not going to go in detail. So this is, you have to keep the elbow and find out how much extension. So this is the amount of hyperextension which is happening. Then as it was said, the flexion is restricted. So this flexion is restricted because of 2 reasons. One is the arc of motion is changed. So whatever is the normal range of motion, it has become hyperextension. So from that hyperextension, it goes to flexion. So the amount of hyperextension is lost in the flexion. But if you see the angle which is lost, the amount of flexion which is lost is more than the hyperextension. Probably around 15 degree you had hyperextension. But the amount of flexion which is lost is almost around 45 degree, more than 45 degree of flexion is lost. So can Azaria, is it right? Azaria, can you tell?
Sir, it is due to the anterior bony block.
Yeah, perfect. So the anterior bony block. So it is not only the change of arc of motion which is causing the restriction of the flexion, it is also the anterior bony block, because the extension type which is common, the proximal fragment, it can form an anterior bony block. So it can prematurely hit the forearm and then it can stop the flexion. So these are the reasons which you have to say about the flexion. Then about the increased internal rotation. So one way of telling is that you keep the elbow fully flexed, like as we showed, by keeping it over the head, and then put the 3 bony point relationship. The triangle would have internally rotated. So if you remember that video, I forgot to mention that. If you want, I can go back to that video. The triangle would have got internally rotated. So that is one way telling that the distal fragment is internally rotated. The second way of telling is that the shoulder is the, because if it is internally rotated, the distal fragment, the shoulder movement, you are seeing it only with the forearm axis. So if the distal fragment along with the forearm, if it is internally rotated, to keep it into neutral position, to bring it to neutral position, some amount of external rotation is already lost. So the patient will have restricted external rotation and increased internal rotation. So that was also very beautifully said. So this is how you demonstrate. So this is the amount of internal rotation in the normal elbow. So if you see the malunited supracondylar, we can very easily demonstrate. So this is the excessive internal rotation which is present. So this much of increased internal rotation says that this much of internal rotation has happened in the distal fragment. This is one method. I hope you all understand. If there is anything, probably we can run the video again. And the amount of external rotation which is lost. So you should show the internal rotation is increased, so which is here, and external rotation is decreased. So this also the change in the arc of motion. So the internal rotation is increased, the external rotation is decreased. So this you have to show and you have to explain it clearly, because we are seeing the rotation of shoulder joint with forearm as the axis. So when already the distal fragment is internally rotated, some amount of external rotation is already lost to bring the elbow to neutral position. So naturally, the normal rotation of the shoulder is always there, but the pointer is wrong. So the pointer shows that there is an increased internal rotation and decreased external rotation. Right. So that is about the supracondylar fracture. So supracondylar fracture, to recap, there will be thickening of the supracondylar ridges, the medial and lateral. The 3 bony point relationship will be maintained, and the components of the supracondylar fracture, hyperextension and internal rotation. So these are the 3 things you have to say, and for confirming your diagnosis as supracondylar fracture. So that is a gunstock deformity or a cubitus varus. Now we will go to cubitus valgus. So again, one more thing is, what is the cause for the gunstock deformity or cubitus varus? So first, common things are always common. Never try to go in for uncommon things. So first say as the diagnosis must be supracondylar fracture, malunion. And so if the examiner insists, can it come in lateral condyle fracture? Can there be a cubitus varus with a lateral condyle? Then probably you can say, or that should be later. So never say immediately. It can happen, but don't be in a hurry to say that. Same way, if it is cubitus valgus, it is commonly a lateral condyle fracture. Lateral condyle fracture, almost always, if it has to result in a cubitus valgus, almost always it is a non-union. So these are all things which you try to correlate and then say. So here, the first and foremost is whether it is a fixed flexion deformity or a valgus deformity. I'll show you a photograph. So there is a cubitus valgus. Okay, so we all understand. But when you look from the side, it looks like a fixed flexion deformity. So this is the maximum extension the child is having. So can Paul say, is it a cubitus valgus when we look from front, or is it a fixed flexion deformity as the child is observed from the side?
For valgus, we cannot say when the elbow is in a flexion, sir.
Correct. So I just want to know whether this is a fixed flexion deformity. I cannot comment about valgus, and this is a fixed flexion deformity, or is it cubitus valgus? I just want to know. How do you say the examiner, sir, this is only cubitus valgus, no fixed flexion deformity, or this is only fixed flexion deformity, there is no cubitus valgus. So how can you clarify?
We have to, sir, we have to check whether there is any flexion deformity by keeping the arm and forearm in the table and check for the flexion deformity, sir. No. Then you have to fully flex the elbow.
Okay.
And check whether the forearm axis is aligning with the arm axis.
Fully flex the elbow, forearm axis is aligning. I
no
can't
varus
get...
valgus.
Pardon me?
No varus or valgus on fully flexion.
Okay, okay. Full flexion, if there is no varus or valgus, you can say that there is no valgus or varus. Is it right? That's what you want to say?
Yes, sir.
Because in flexion, you cannot comment. Is it right?
Yes, sir.
So that is entirely different. I just want you to tell, is it a fixed flexion deformity? Now the child is standing like this. Obviously, there is around 30 to 35 degree because it is almost in the axis. The arm is along the axis of the body. Yes, and she is not able to extend further, believe me, because this is my patient, this is my hand. So she is not able to extend fully. So is it fixed flexion deformity? You look from the side, it is like this. Or is it a cubitus valgus? So we can go back. Or this is cubitus valgus. Which one is right? Or
we have to passively try to passively extend the elbow.
Oh man, this is maximum which is possible.
Okay.
So there is some error which I am trying to show also. So that error, if you keep it right only, then you can decide whether it is cubitus valgus.
Hand is in pronation, sir.
Okay.
Forearm is in pronation.
Right, but you can supinate it, but it is still remaining the same. You can supinate. So, can Azaria say something?
It is in, rotated.
Which one is rotated?
The shoulder is internally it is rotated.
Very good. Agree. So if it is internally rotated, the cubitus valgus will look like a fixed flexion deformity. If it is externally rotated, it will look like extension valgus. I agree. But how do you make sure that it is not rotated or it is in correct rotation?
The medial and lateral epicondyle should be
along. Yeah, exactly. So this is one of the most important point in a cubitus valgus. So this is what I am trying to show. So they are not in the same plane. This is lateral epicondyle. This is medial epicondyle. So this is obviously internally rotated. So if it is internally rotated, the valgus deformity will look like flexion deformity. So you have to keep both at the same plane. Then only you can. So this is the same plane. So if this external rotation, because the child normally stands like this. I have not asked her to stand internally rotated. She cannot stand with so much of valgus. So she tries to internally rotate. And when you look from the side, you cannot extend beyond this. It looks like a fixed flexion deformity. So to make it obvious, to unmask the deformity, you have to keep both epicondyles at the same level. So when both epicondyles are at the same level, then it is valgus and it is not fixed flexion deformity. Very good. So this is a very important point. Then you have found out what is the cubitus valgus. Then you have to be very, very careful in trying to palpate the lateral epicondyle. And then you have to find out whether there is any yielding. So if it is more than 3 months, very difficult, 3 to 6 months for getting an abnormal mobility. There will be fibrous union. Even on the table, it is very difficult to move and find out where is the non-union site. So you may have to use a needle, you may have to use a C-arm to find out where it is when you are doing some surgeries. So being that the case, you have to be very careful. Or you will have to tell the examiner in your diagnosis, this is cubitus valgus due to lateral condyle fracture. This I am not able to elicit abnormal mobility. If there is yielding, because you have to flex it, you have to hold the lateral epicondyle, the condyle, lateral condyle, and then you have to move anteroposteriorly to elicit. With your thumb, you can move or we have to use with both fingers, thumb and index finger, and try to move anteroposteriorly, find out whether there is any abnormal movement. In spite of that, you have to say, even if you're not getting it, so I will expect only a non-union, but because of the fibrous tissue, I am not able to elicit abnormal mobility. Still, I would put it as a non-union lateral condyle with cubitus valgus deformity. Don't say straight away as a malunion. So that is one. And for finding out which is the lateral epicondyle, many a times there will be a problem. So how do you know this is lateral epicondyle? So what is the landmark for? Because if there is a thickening, if there is irregularity, how will you say that this is lateral epicondyle? Paul?
Sir?
Medial epicondyle is very prominent. So you can always easily find out. But lateral epicondyle, it is not as sharp as medial epicondyle, and you will find difficult if there is a lateral condyle fracture.
Yes, sir.
Yes.
Yes. First, we have to find the soft spot, Anconis triangle.
Right. Okay.
Then we have to go the proximal, and the first bony prominence is the lateral epicondyle.
So going from a soft spot to the lateral epicondyle may not be the right way. What you are saying is right, but that is not the right way. The distal most and the lateral most point of the humerus is the lateral epicondyle. That is what we will expect you to say. Instead of going from the soft spot above, so you have to say the distal most and the lateral most point of the humerus is the lateral epicondyle. So you have to see the lateral epicondyle. Okay. So then you are finishing it as a lateral condyle fracture, and then you have to say. Then coming to the supination and pronation. So you will have to, you cannot just see passively and then try to say what is supination and pronation. So though this is only elementary and undergraduate level, this you will have to see. So you hold it on either side, see the fingers are splaying, this is increasing the pronation. He tries to increase the range and then try to say that this is amount. And how much is the restriction? So you have to take the pen or a sharp, a point, longer point to measure how much of supination, fixed supination deformity, how much it is restricted. You have to say everything. You have to be very, very objective. You cannot say that he has got a supination deformity and the pronation is restricted, all those kind of things. So you'll have to be very accurate. Around 45 degree of supination to 45 degree of pronation, something like that, you'll have to say. So for that, make sure the arm is by the side. It is preventing the rotation of the shoulder, which can increase or decrease the supination. So once this is tucked, the arm is tucked by the side of the body, you give a pen or something and then ask him to supinate and pronate. Always make sure he need not overdo it by rotating the wrist and splaying the fingers and increasing the range of movement, keeping it loose. So he has to hold it the same way, gripping normally as possible, and then he has to move. So that is how you measure the supination and pronation. Oh my God, again I'm doing it. So then you have to palpate the other bony landmarks. The olecranon you will always know. You can palpate from the subcutaneous border, the part of olecranon, it is easy. How do you see for the radial head? Many a times, because radial head, it is a smooth, rounded bony mass. And if you rotate, if there is something like a greater lesser tuberosity of humerus, something which is touching your thumb, you'll know that there is the head of humerus. Imagine that it is a round object. If you rotate, then you will not be able to feel the round object moving because it is very smooth under your thumb if the radial head is normal. And added to that, if the patient is obese or if he is very muscular, almost it is very, very difficult. So I'll always say my students to find out where is the radial head, especially if it is displaced. If there is a Montague lesion, radial head anterior or posterior, then it is always easier to see, inspect rather than to palpate. So if you see here, so just see here. So the radial head coming and going. So he is supinating and pronating. So this radial head, which is, so you can see, trace the shaft and see the radial head and then keep your hand there. So how do you palpate for the radial head if the examiner asks? The lateral condyle in a flexed elbow, below and in front. So this is the place where you're looking for radial head. So if there is some problem in the lateral condyle, if there is something, so I'll always say that it is easier to see than to palpate because being very smooth, rounded object which moves smoothly under your thumb. So you just observe, see, and then palpate. Look for any irregularity, whether there is any radial head. Then, as it was previously mentioned about unconeous triangle is formed by, can you say, Paul?
Sir, olecranon, tip of olecranon, lateral epicondyle, and radial head, sir.
Very good. So, what is the significance of unconeous triangle?
Any boggy swelling can be seen easily, sir. Any swelling or effusion.
Yeah, effusion or swelling of the joint can be visualized easily. So, this is how you make draw the unconeous. So, this is the tip of the olecranon. Mark it. Then the lateral supracondylar ridge, you just palpate. So the distal most and the outermost. So that you mark it as the lateral epicondyle. And then you palpate the radial head. So it should be the same flexion. So you cannot be flexing and extending. So you ask him to move, and then I think he is marking it little more anteriorly. So that the unconeous triangle cannot be so much. But anyway, so this is how you mark the triangle. So if you want to aspirate, if you want to see for the effusion, so this is how you do it. So this is my own brother. He sustained a radial head fracture on the right side. So this is the normal unconeous triangle on his left side. And if you see, there is a prominence here. So immediately following a radial head fracture. So this is the swelling in the unconeous triangle. Hope you are able to appreciate that. Then finally, you must never forget about elbow instability. So this elbow instability is one you have to elicit in all cases. Find out whether the elbow is stable or not. In which position you will examine for elbow instability, Azaria? How will you look for elbow instability?
30-degree flexion, sir.
Why do you want to flex to 30 degree? 30 degree, I feel it is okay.
To unlock the elbow joint.
Where is it locked?
Sir,
is it something behind? The poplite is locking?
No, sir. Normally, the trochlea, ulnar trochlear joint is, when it is an extension, it behaves as a single unit, sir. So to...
No, why is it? Trochlea is something like a concave surface, like a saddle. And correspondingly, the ulna upper end of proximal end of ulna glides. So whether you flex it or extend it, the corresponding part of the proximal end of ulna articulates with the trochlea. By flexing it to 15 degree or 30 degree, what are you trying to achieve? You are right, but you are not. Your explanation is not right. How is the elbow you feel it is locked? Paul, you want to say?
Tip of olecranon from the olecranon fossa.
Correct. So the olecranon engages the olecranon fossa in full extension. So that prevents, even if the elbow is unstable, that prevents the instability being manifested. So it looks like it is stable. So you have to flex it. Second, what is the most important thing? You have to find out a confusing factor. What is that you want to stabilize, or which can give you a false unstable feeling? One is the olecranon, which makes it stable. So you have to flex it to elicit instability. What else you have to be wary of? You have to be think.
Sir, neutral pronation, supination.
What way is it going to affect? In supination and pronation, is the ulna going to change its position?
No, sir.
Well, it is not going to change. So which changes actually?
Radius.
Radius sweeps over the ulna. So whether it is, so in instability, what are you checking actually?
Humeral ulnar joint, sir.
Correct, humeral nerve. So supination pronation is not going to do anything else. So the shoulder joint is one. If it is not stabilized properly or you are not being very careful, the rotation of the shoulder will give you a feeling that the elbow is unstable. So you'll have to make sure the epicondyles are not moving. It is stabilized. The elbow is flexed, and then you'll have to see. So if you see that it is little flexion, so you have to palpate the epicondyles. If you see inside it is not moving, and see whether there is a instability. So both epicondyles are held, and then look for the instability. Okay, the shoulder is not moving. So this is how you elicit the flexion of the elbow, hold the epicondyle and make sure that the shoulder is not moving, because otherwise the rotation of the shoulder will give you a feeling that as if the elbow is unstable. So that you have to be very careful. So to complete, so once you have done all those things, you have to palpate for the ulnar nerve. Ulnar nerve is very, very important, whether it is in position, whether it is thickened due to any other pathology, whether there is any tender neuritis which is happening if there is constant friction, or is it dislocatable? Most important, in a cubitus valgus, is it in the right place or is it dislocating? And of course, you'll have to see for the function. Even though you are going to see the entire distal neurovascular deficit, ulnar you have to be very, very careful because of the ulnar paradox. Deformity may not be very obvious if it is at a higher place, and then the ulnar nerve may be still, and it is not this cubitus valgus and tardi ulnar nerve palsy. The entire ulnar nerve need not be completely functionless. So there can be some function happening. So subtle paralysis, subtle involvement of the ulnar nerve, you'll have to find out whether there is a subtle clawing, whether there is paresthesia, whether there is any numbness on activities. All those things you'll have to elicit. Then comes the measurement. So what are the measurements you will make? So how will you measure? So you have to mark all the points. You have to see the olecranon. First is the 3 bony point relationship. So keeping it in the same place. I think it is again a repetitive video, but anyway, you have to measure because it forms a scalene triangle. Don't say it is an isosceles triangle. Isosceles is 2 sides are equal. Here all the 3 sides are not equal. You'll have to keep it flexed, keep it in the same position if it is a fixed flexion deformity or range of movement is restricted. And then in that position, you mark everything and measure from the medial epicondyle to the lateral epicondyle, intraepicondylar distance, lateral epicondyle to olecranon, and medial epicondyle to olecranon. Always mark it and then measure it. Otherwise, you just keep the tape over the place where you think the points are. You may not be able to show to the examiner, or you may not be able to repeat the same thing. So you will have to measure. So in extension, it will be a straight line, so it doesn't form a triangle. In flexion, you have to see that too in the same position, how much it is. So here it is around 6.5 centimeters. And here, if you see, it is almost 7.5. It is the same only. Oh, this is from olecranon to the lateral epicondyle. That is previously it was 3.5 each. So here it is now 2.5 and 6.5. And if you see the intraepicondylar distance, previously it was 6.5. Now it is almost 8. So Azaria, what is the diagnosis in this lady? What do you think is the most common diagnosis in this?
Distal humerus intercondylar extension.
Okay. So distal humerus, because intercondylar distance is increased, the olecranon to lateral epicondyle, medial epicondyle is also altered. So this is something like a max. So it is widened, distal humerus is widened. So this is an intercondylar fracture with a supracondylar with an intercondylar extension. Then the limb length measurement, the angle of acromion. So that is where the acromion changes, turns. So that is the angle of acromion you mark. And then you mark the lateral epicondyle. So from angle of acromion to lateral epicondyle to the radial styloid. So this is how you measure the limb measurement. You mark it and then measure it. Okay. Then how do you measure? That was also very well mentioned last class. So in the anterior axillary fold, from the anterior axillary fold to the lateral aspect, you take the midpoint, and the medial and the lateral in the cuticus fossa, you take the midpoint, connect the line, and the radial styloid and the ulnar styloid, take the midpoint, connect the lines. So then you keep the goniometer and then accurately say how much. So it should be extended, supinated, make all the points, and then you measure. And you also measure it in the normal side and then say how much of varus. This is very important for doing your correction. So before you finish your examination, if there is any problem in any disturbance in the radius or in the ulna, you must always, because these are the things which now it might appear very simple. Yes, if there is a radius fracture, if there is a radial dislocation, you have to see the distal radial nerve joint. Many a times people don't see that. So whether there is any DRUJ, instability, ballotability, it comes as a part of the examination. So you'll have to see whether the relationship of the radius and ulna is altered. A Montague fracture, a distal radius fracture, or a proximal radial head dislocation, whether there is any DRUJ instability. Then you'll have to say the shoulder and wrist, proximal and distal joints. And then entrapment neuropathy is one thing which you have to be wary of. The tennis elbow, the commonest differential diagnosis is supinator syndrome, the posterior interosseous nerve getting entrapped. So you have to see whether there is anything. And the neurovascular examination, never forget it. So radial pulse, ulnar pulse, and then the neurological examination. So with that, if you have been meticulous, if you have been following all the steps, if you did not miss anything, never bother about the X-ray. So if you have told everything and if you have done, if you are asked to demonstrate, if you are able to do everything, then you will not have any problem of the case. Forget about the X-ray. So the take-home message will be inspection is very important from anterior, lateral, medial, and the posterior side. Measure the mention about the carrying angle, and it has to be extended and supinated, and you have to see the carrying angle. Assess the deformity properly, whether it is a flexion deformity, valgus deformity, or a varus deformity, and keep the epicondyles at the same plane before you tell about the deformity. Otherwise, it can mislead you. The supracondylar ridges you have to palpate. You have to palpate for the 3 bony point relations, which is very important and you will not miss. Palpation of the ulna and radius, and along with that the ulnar nerve. An abnormal bony mass, definitely. Whether it moves, if it doesn't move, whether it is warm or not, to say if it is a myositis ossificans, which is very, very common, whether it is restricting the range of movement, where is the mass which is situated, whether it is quiescent or is it active. Quiescence is that there will not be any tenderness, it will not be warm, and it will be, in the X-ray, it will be well defined. If it is active, it will be warm, it will be tender, and cottonwool appearance, the margins will not be very clear and obvious. Then you have to see about the range of movement and about the instability, and it cannot be complete without telling about the neurovascular examination. I think with that, we'll reasonably conclude the elbow examination. So if there are any questions or anything, I think we'll go ahead. Suresh, you are muted.
Azaria and Palram, you have any questions? You will straight away ask your professor. Any questions from you?
No, sir.
For Azaria also, no? Any questions?
No, sir.
No. So there is a first question from the chat box, sir.
Yeah.
Sir, in case of lateral condyle fracture non-union, being a non-union, it should be painless. But when the same patient is associated with a valgus deformity, it becomes painful. In the examination, the examiner asks what is the cause for pain.
Yeah.
Being a non-union, why there should be a pain? This is the first question they have asked.
Okay. Azaria or Paul, anyone wants to answer? That's a very interesting, very good observation.
No, sir. It's a intra-articular fracture and mainly intra-articular. Synovium surrounded by synovium.
Okay. So what? What is the cause for pain? So the pain is because when you are moving the upper limb, it is not only the range of movement which is happening like an hinge joint. So whenever you are lifting, there will be an abduction moment, there will be an adduction moment when you try to lift, when you are writing, when you are sitting. So all these things will cause an adduction stress or an abduction stress. So being an instability there at that non-union site, so it produces fatigue and it produces pain. So the pain will not be there when you are palpating. It is not tenderness which is there. It is the pain which is produced because of the instability. So that is one of the important indication that you will have to fix the non-union fragment. You need not align it properly, but you will have to achieve union of the non-union fragment, ununited fragment to the humerus for along with correcting the deformity. So it is because of the instability while force is applied that produces pain rather than the tenderness at the non-union. Non-union will not be tender.
Okay. So in the examination, the examiner asks, where is elbow joint line? What is the way to answer, sir? Whether it is the radiocapitular line, the anconeus line, or the tender spots on the posterior aspect on either side of the triceps. Which one to say? Elbow joint line. The examiner, tell me what is elbow joint line?
So the elbow joint is situated at the anconeus triangle.
Okay, sir.
And the joint, where it can be palpated.
Yes, sir.
Or, but if you are asking about the joint line, on either side of the triceps and a flexed elbow, where it gets, that is the right. But I am not very sure about it.
Okay.
Yes.
Okay. Thanapan, you have a question. You have written in the chat box. Can you elaborate straight away, sir? Thanapan? Where is Thanapan?
Suresh, you can ask, sir.
What is that? Your supratracheal node.
Sir, where to look for this epitracheal node, sir? Is it the same place where you examine for ulna now or a little bit different?
No, just above that. And the medial aspect, above the medial epicondyle, you have to roll your finger from anterior to posterior along the medial supracondylar ridge.
So same method of ulna now.
Yeah.
This area we look for ulna also.
Yeah, correct.
Thank you,
sir. Sir, Thiru here, sir.
Yeah, Thiru, tell me.
Sir, excellent presentation, sir. Abdiye enak PG abdiye nyavam vandiruchu, sir. Neenga edukra class. Sir, one small doubt, sir.
Yeah.
So suppose there is a lateral condyle fracture where you're not able to feel the lateral condyle properly.
Yeah.
How will you do the measurements, sir? Because this confusion will be there for every postgraduate. When there's a varus deformity with a malunited supracondylar fracture, it becomes easy, sir.
Yeah.
But during where your lateral condyle you're not able to fix up the epicondyle properly,
so
then how will you do the measurement of both arm and forearm?
Correct. So what I will always say is, so lateral epicondyle is very, very, it is not very sharp, yes, like a medial epicondyle. That's why I say that distal most and lateral most point of the humerus, you consider it as lateral epicondyle, because in a lateral condyle fracture, it would have rotated in its vertical axis 180 degree and in the horizontal axis 90 degrees. So entire thing is rotated. So you
will it give a correct measurement, sir? I understand that we can take for 3.1
measurement. Definitely, it will not give it will not give the correct measurement.
Okay, so linear measurements, we cannot be absolutely sure whether there is any difference.
Yeah, exactly.
Can we tell like that in the exam, sir? That's what for the sake of
because it will be rotated. If it is lateral condyle, I expect it to be rotated. So, but the lateral epicondyle is assumed to be the distal most and lateral most. That point I have taken and I have measured. Because for three bony point relationship, as well as for the limb longitudinal measurement.
Yes, sir, linear measurements also. Sir, and one common question, sir. And in that case, can we measure from the olecranon, sir? In that case, if you're not able to get the lateral condyle properly, but theoretically we cannot say, sir. But in that case, practically, can we say that I've taken measurement from the olecranon?
Again, the olecranon will be, because the arm measurement may not be right because of the tilt and because these are all it is not described, but still you can say the examiner, because I am not able to say and this is not very sure, so I have taken like this. You can say.
Okay. That is, and what about the circumference of the elbow, sir? Where exactly can we take the circumference of the elbow? Suppose there is a effusion, and suppose there is an elbow effusion.
Yeah, at the epicondylar level, probably because of the malunion. So you must be able to say, if there is an effusion, the interepicondylar distance, if it is by going around the effusion, then it might give a false reading of that is increased, where there is nothing in the elbow. So you can just take the circumferential measurement and then say that it is increased.
Okay, sir. Yeah. Thank you, sir. No, these confusions will happen in exams, sir. It will not be a straightforward elbow. Sometimes they get confused as to the measurements. That's why I just wanted to.
Yeah, correct.
From your words.
Yeah. Sir, you mentioned, you shown excellently how to measure the sagittal plane, this varus and valgus, sir. Just for the sake of postgraduate, how to measure the flexion extension movement with goniometer, sir. Just for the
along the axis of in the lateral side, if you can take. So along the axis of that is how this thing was also in the mid-prone position. But you can just take the ulnar as the point and the axis of the arm with the lateral epicondyle as point and above the midpoint of the anterior and posterior border.
Exactly where to take in lateral epicondyle, sir? In the middle or in the posterior one third and the anterior one third?
I didn't get that. Lateral epicondyle.
The 0 mark to be taken in which point of the lateral epicondyle, sir?
Because I always say, don't worry about where it is, whether it is exactly lateral epicondyle or not. The distal most and the outermost point of the lateral aspect of the distal humerus is the lateral epicondyle. So wherever it is, don't take it anteriorly or posteriorly, because the lateral epicondyle where we take may be little anterior. So those things, don't worry. You just take it as a lateral epicondyle and the mid sagittal aspect of the arm.
Okay.
Is there any other questions from the audience? Any other questions? That was an excellently covered topic on the clinical examination of the elbow. There are a few things which will be confusing you at the time of examination. So I advise you to see this video before your examination, how to keep the elbow position. These things in your tension, in your last minute preparation, you may fear, you may forget. Again, go through this video after a few days, you'll get it corrected and start practicing this in your day-to-day practice, then your day-to-day presentation, then it will get fixed to your brain and there will be no issues in your passing the examination. I thank my professor.
One more question, sir.
Yeah.
Sir, sorry to interrupt. Sir, most of the patients are coming with native treatment, sir. So most of the patients are presenting with the flexion deformity only. Suppose an isolated supracondylar fracture which has gone for cubitus varus deformity, presenting with the isolated flexion deformity, then how can we commit a clinical diagnosis of malunited supracondylar fractures? You have to go only with the supracondylar ridge thickening because we cannot measure the varus at all in this case.
Yeah, definitely. So if there is no varus, that need not be a problem. Supracondylar ridge, childhood, and the 3 bony point relationship is maintained, then we'll have to go with that one. And you will have to say as post-traumatic stiffness due to massaging. And if you are able to palpate the myositis or something, then it will add it to your diagnosis.
So in that case, how to frame the diagnosis properly, sir? How to give a proper diagnosis? Can we state as a post-traumatic deformity or something special words we have to use, sir, for giving a proper diagnosis?
No, post-traumatic stiffness following a malunited supracondylar fracture.
Okay, sir.
Or whichever side.
Sir, and one more doubt, sir. One more doubt. Sir, when before inspection, we say the attitude of the limb, sir.
Yeah.
So in the attitude of the limb, what should the PG say? Can he directly say there is a cubitus varus deformity in attitude?
No.
Or he should say there is an angulation or something like that, sir. But obviously, when there is an obvious varus deformity, can't he commit that in the attitude also, sir?
Definitely. Attitude and deformity. Attitude is which position the limb is kept. Deformity is the deformity what the joints are having. So in the attitude, arm by the side, elbow extended, forearm supinated, wrist and finger in position of ease. Deformity is that the patient has a cubitus varus.
Sir. Deformity. I mean the deformity only.
Yeah, deformity definitely. So this is how you have to, any joint if you are describing, attitude, deformity, muscle wasting, apparent limb length discrepancy.
Limb length. So we sometimes some examiners will not say straight away, you should not say cubitus varus. You should say there is an outward angulation or something like that, sir.
There are funny examiners. Examiners are very funny. Students that get confused only because of the examiner. Whether this makes any sense or not, we do not know. So sometimes when we are there, we'll be able to tell this is how we have taught them.
Yes, sir.
But anyway,
Yes, sir.
if it need not be, because if the elbow is extended, epicondyles are at the same plane, forearm is supinated, definitely you
Yes,
can
sir.
say the carrying angle is decreased, increased, or cubitus varus deformity. That too in a short
Yes.
case. Definitely you can say.
Yes, sir. So PG should be more interactive, and they can ask the questions now itself, so that just before the exam, they they don't have much time for exams as final years. So
we expected more questions from the postgraduates. I think they are busy preparing for the theory.
Yeah,
I mean, these are only subtle points which they will learn only by people like sir, because these are only subtle points that exam they will get confused, sir. If they know these subtle things easily, they can pass.
Definitely, absolutely. They get confused
Normal
and then
things,
they get depressed, and then they
yes,
start saying something.
The normal things they will answer. So only these subtle things that it will add to their presentation,
Exactly.
and the examiner will be more impressed by that.
Exactly, exactly. What you're saying is absolutely right.
Yes.
I think Suresh can wind up. Yeah.
Suresh? Okay, sir, I will wind up. Thank you so much, sir. It's an excellent talk. It's a privilege to listen to this talk, sir. We have learned a lot from you. Thank you so much, sir. Thank you so much for your time in a short notice. And, giving this lecture.
I just want to mention that I was a substitute player when the main player did not come. So I had to act as a substitute. So I can do whatever I want and still get away with that as a substitute player. Okay, thank you.
Thank you.
Thank you.
So much, sir. Thank
Thank
you all
Thiru, for all the interaction. Yeah.
Okay, sir. Thank you, sir.
Thanks.
Ramesh, sir, you can close it. You can close the program.
Yes, sir. Thank you very much.